Hola a todas y todos. Vamos a dar inicio a la conferencia que nos convoca hoy día. Mi nombre es Jorge Ramírez, yo soy el director del programa de salud global de la Escuela de Salud Pública de la Universidad de Chile. Y en el contexto de un proyecto de investigación que estamos realizando hace ya varios años, entre otros con la Universidad de Ottawa, tenemos la oportunidad hoy día de discutir un tema que es bastante relevante, especialmente para nosotros y para los debates que se están realizando respecto a las posibles reformas al sistema de salud en Chile. Para eso nos va a acompañar el profesor Ronald Labonte, que viene de la Universidad de Ottawa, que es el líder de este proyecto que yo les comentaba respecto a diplomacia en salud global. Él tiene una presentación acá, va a durar aproximadamente una hora y va a estar abierto a que hagamos preguntas. Nosotros vamos a grabar esta presentación, por lo tanto, si tienen preguntas, vamos a tener que usar este micrófono que tenemos para que se pueda escuchar la pregunta y la conversación con Ronald. La presentación va a ser en inglés, las láminas que ustedes van a ver están traducidas. Si eventualmente alguien quiere hacer alguna pregunta en español, podemos ayudar en la traducción. Okay, so introduce yourself. I said that the presentation is going to be in English, yes, with the slides translated, and if someone has a question in Spanish, we can translate it for the purpose of this presentation. So we're very happy to have the Professor Ronald Labonte here, and we are very anxious to know about the answer of the question that is in the slide. So, Professor.
Okay.
Gracias.
Ella parece que está visto, tiene experiencia.
I've done this before. Okay, hola a todos y a todas. This is your opportunity to practice listening in English, for which I apologize, but that's the way things go. As we know, there's a lot of movement now around health system reform. And 40 years ago, we had a conference at Alma Ata, which issued the famous Declaration on Primary Health Care. But as I'm going to talk about, the rather comprehensive vision of that declaration very quickly got sideswiped and moved into a very selective, marketized system. There's been efforts to try to shift that again, but they've mostly been defined as universal health coverage, part of the Sustainable Development Goals, and the number one issue of the former Director General Margaret Chan at WHO, and now still the number one issue of the new Director General, Tedros. So the question is, are we actually moving forward with a progressive health system reform, or are we still being trapped very much in the neoliberal economic paradigm that saw so much kind of destruction of health systems during the 1980s and the 1990s? It's actually a rhetorical question because by and large the answer is yes, we're stuck there. But there are some glimmers of moving forward. So, to begin with again, some of us in this room, at least, were alive when the Alma Ata Declaration was made in 1978. And it was a joint effort of the World Health Organization and UNICEF. And it took place in Alma Ata, in one of the Russian stands, the Soviet Union stands, Kazakhstan. It's now called Almaty. And at the time, it was really a period when we had a lot of the former colonial countries in Africa and in Asia and in the Pacific were decolonizing. We were at a height of a kind of a Cold War that had not yet finished. And there were experiences in many countries of trying to provide some more effective primary health care to people who previously had not had access to any health services. The barefoot doctors in China, the lady health visitors in Pakistan, a number of other initiatives, including an attempt to create comprehensive community health centers in apartheid South Africa. That was not part of the official government policy in South Africa at the time. So it was really at this Alma Ata conference, it really was a consolidation of what had already been learned in some of the more progressive countries attempting to develop a more comprehensive model of health systems. So the declaration is remarkably short and simple in many ways. But it does raise immediately, with the bolded words on this slide, issues about how to interpret Alma Ata and the Declaration. If we look at essential health care, did that become an invitation to move immediately into selective forms of medical care? Was full participation really about the empowerment of people, or about getting poor people in rural communities to perform as voluntary laborers, building the centers, stocking them, paying for their services? And the problem of first level of contact, well, that's very much still a part of primary health care. But that allowed the vision of Alma Ata to very quickly simply become primary medical care, primary care. Nonetheless, there were some basic principles in Alma Ata, which I think are still very impressive and very important principles. Accessibility based on need, so we have equity really is at the heart of the Declaration. The comprehensiveness of care. And one of the things that Alma Ata emphasized was moving all the way from rehabilitation services through direct care or primary care services to disease prevention and health promotion activities to actions on social determinants of health. They didn't use that phrase then, but what they talked about potable water or sanitation, they talked about food security. So there were a large number of issues that the Alma Ata Declaration recognized had to be acted upon, in part by health systems, in order to promote or achieve health. Intersectoral actions, recognizing the need to work across government silos to achieve health for all, and appropriate technology. And that was important because so much of what was beginning to happen, and because the Declaration never really did succeed in setting the template for health system reform, what subsequently did happen is that a lot of the health financing, public or private, went into technologically driven medicine in high-tech hospitals in urban areas that were accessible only by a very small percentage of the population. So while Alma Ata recognized that this could occur and was occurring, it emphasized appropriate technology. Now, the real champion of primary health care was Halfdan Mahler, who had a very long tenure as Director General of the WHO. And he kind of initiated this phrase, this concept of health for all by the year 2000. Of course, for reasons I will get to in a moment, we never got there to health for all by the year 2000. And I'm part of the People's Health movement, and when we had one of our People's Health assemblies in Cuenca, in Ecuador, where I got to launch the first of the Global Health Watch series of books. I had also just published a small book based on one of my contributions to Global Health Watch. And Halfdan Mahler was there and was being honored for his work around health for all. And I could run up to him and I gave him my little book, because on the cover I had retitled and it said, Health for Some, which is really, unfortunately, what we had achieved by the year 2000. But it was an optimistic time in 1978. There had been periods of sustained economic growth throughout the 1960s and the 1970s. The former colonies had declared their independence. There was still a kind of a push-pull between the capitalist systems that occurred in Europe or in North America and the more socialist systems, or kind of at least communist systems. We had the two bloc, the US and the USSR. As a consequence of that bipolar difference, that residue of the Cold War, many of the newly independent former colonies were able to play the politics off against each other and try to develop a more of a mixed economic approach to their development. And the UN itself recognized this some years earlier in 1974, where they stated the Declaration on the New International Economic Order. And the United Nations at that time, the General Assembly, regarded this declaration as the most important declaration they had ever made. And the principles of this economic order were basically to ensure that all of the fruits of economic activity in an international economy would disproportionately benefit developing countries. So it was a statement of kind of creating a different economic model than the one that had persisted during the period of the Cold War. Unfortunately, what we know happened is that we wound up not getting a new economic order, but instead we got a new, or shall we say, a neoliberal economic order. And very quickly, the Alma-Ata Declaration and the Declaration on the New International Economic Order disappeared. People no longer talked about it, especially about the New International Economic Order. What's important is that the Alma-Ata Declaration specifically referenced the New International Economic Order of the United Nations as being the foundational element to being able to provide a comprehensive primary health care system in countries. I think few of us would disagree with these principles. And in many ways, the older cohort of Lee activists in primary health care continue to try to push and prod to have these principles be better formulated within, again, UN declarations or agreements. So why didn't Alma-Ata take hold? And the backstory on this is fairly well known to many of us. We had the oil price shocks in the 1970s that quadrupled the price of oil. So developing countries that were reliant on oil imports for their development or their growth all of a sudden saw the costs of those imports skyrocket. Meanwhile, First World banks were busy throwing loans out to developing countries in a reckless, profligate way. Those loans were usually 1 to 3 years in duration, and then they had to roll over and be refinanced. Meanwhile, one of the episodic crises of capitalism in the high-income countries led to something called stagflation, no economic growth and high inflation. And the response to that, the first Volcker shock it was called, was to suddenly raise interest rates from 4 or 5% to 18 or 20%. It's called a monetarist policy, the idea being you had to reduce the amount of money in the system in order to bring down inflation. Well, this was fine for high-income countries, more or less. I remember having to renew my house mortgage at an interest rate of 18%. I wasn't terribly happy, so yes, many of us were affected. But it was particularly devastating for low-income countries because when their loans became due, money they had borrowed at 6 or 7%, they were now being charged 30 or 35%. So instantly, the level of their debts magnified. And that created the context in which we had the first, in a sense, global financial crisis, when Mexico declared it could not honor its foreign debt. And there was a risk of what we now call sovereign debt default. Now, this totally freaked out the world's financial system. So they immediately went over to the groups like the World Bank and the International Monetary Fund. So we need to do something. Meanwhile, these two institutions had been taken over by economists who had been trained at the University of Chicago and been brought up on neoliberal principles. I emphasize that they were brought up or taught neoliberal economics because when they imposed these structural adjustment programs on low-income countries, they didn't do it because they were mean, nasty, awful people. They did it because they were true believers in a neoliberal economic theory that had never been tested before. The problem with that, of course, is we wound up with structural adjustment programs. And those programs essentially led to privatization, liberalization, marketization, cost recovery in different health and social programs, and a welfare minimalism. And although the idea of structural adjustment was to stimulate growth in poorer countries, so that then they could diversify their tax revenues, diversify their financing for their health or education systems, that never happened. And instead, what they really accomplished was they allowed poor countries to pay the debts back to the private banks in high-income countries. If this sounds a little bit like the outcome of the 2008 financial crisis, that's exactly what it is. The 2008 financial crisis is what happened in low-income countries in the 1980s, except this time, very few countries were spared. So, as a consequence, immediately it became difficult for low-income countries to consider how they would finance the vision of primary health care in Alma-Ata. So then we have entered barely a year after the Alma-Ata Declaration, this idea of selective primary health care. The things that people could afford to do, that countries could afford to put in place, with a very strong emphasis on diseases, a very strong emphasis only on the most marginalized communities. It was supposed to be just an interim or short-term measure. But somehow, with the rise of neoliberal orthodoxy around the world, it's become an entrenched permanent issue in primary health care. Now, we did have this thing called Gobi Triple F. UNICEF actually promoted selective primary health care on the basis of improving child health. So growth monitoring, oral rehydration, breastfeeding, immunization, food fortification, female education, and family spacing. So that's the Gobi triple F. Now, the good news is that it succeeded beyond even the expectations. And infant mortality rates actually dropped enormously as a result of these very low-cost interventions. The bad news is that it did not lead to a sustained or sustainable health system and did not deal with the kinds of health issues or problems or the determinants of health that these children would face once they passed their 5th birthday. So it was a partial measure, very successful in a partial way, but it still did not really address all of the important issues that need to be addressed in health system reform or in health promotion. So it led to this vertical programming because it also diminished the state-funded responsibilities. Many donor nations became involved in providing funds for these very selective programs, and countries and governments could kind of back away and not necessarily fulfill their responsibilities. And fundamentally, selective primary health care ignores the social context in which illnesses arise. So this was prior to the time when we had the Commission on Social Determinants of Health. We just focused on very narrow, specific interventions. And if you look at how most health funding globally today continues, it still follows that model. Not totally. Some of the global funding mechanisms try to build in more health system development, more health worker support, but they're still driven principally by providing short-term results, not long-term sustainability. So what we see as a consequence in terms of the results of this neoliberalism was this increased marketization of healthcare, imposition of user fees, privatization, and also this huge increase in the growth of private hospitals. Some of this was in Latin America. A lot of that growth was in South Asia. And we know from research in South Asia in particular that these private hospitals deliberately over-service patients to the point of actually killing them with their over-servicing because they're driven to create or generate more revenue or more profit for the owners of those private hospitals. We have problems. Underfunded public sector, and that persists in many low-income countries. The result of not having a good health system in many low and middle income countries drives trained health workers to migrate. And I've done a lot of research in health migration, health worker migration over the years. And we used to talk a lot about how high income countries were pulling health workers out of low and middle income countries. The reality is that it's not so much that high income countries pull them out as the conditions under which health workers in low and middle income countries work pushes them out, understandably. And then many countries moved into the area of medical tourism, another area that I've been doing some research on, where in order to attract more revenue for the private hospitals, let's try to attract fee-paying, wealthy international patients. That again, both of these phenomena, the health worker migration and medical tourism, pose significant risks to health equity or health accessibility for low-income people within those countries. So, 10 years ago, the World Health Organization decided that it needed to revisit some of the ideas around primary health care, 30 years after Alma Ata. What it pointed out significantly was the comment that about how health systems have grown to disproportionately emphasize very narrow specialized curative care. The very reason why Alma Ata originally emphasized appropriate technology. Also that they existed as a command and control to very specific diseases and very fragmented health systems. And much of that had to do with the behaviors of donor nations and the competition amongst different NGOs and donor countries to provide certain specific programs that would show short-term results. And then unregulated commercial services and the huge growth in unregulated commercialization. So WHO said we need to kind of shift our thinking around this and try to consider how we would rebuild a health system on principles of primary health care. A great report, not very much happened as a consequence. However, again during the People's Health Assembly in Cuenca, where I got a chance to meet Hofden Maurer, we birthed this strange project. We came up with this idea for a strange project. We thought that in many little pockets around the world, there were efforts that were being made in a more localized way to create more comprehensive primary health care based on some of the ideals of the Alma Ata Declaration. So we got funded to do a 4-year study. Big literature review to start with, which is what you always do with a new study. But we had 20 projects in 16 countries and 4 regions of the world. It was absolutely crazy. David Saunders at the University of Western Cape was the other leader on the project, along with me. We just kind of said, what are we trying to do? On almost no money. We had money, but hardly enough money. And part of what we tried to do with this project is we wanted to make sure that we had research teams that had 1 junior researcher, 1 senior researcher, and someone who we called a knowledge user, which could be someone from the health system. In one case, it was the Deputy Minister of Health for the country. So it ranged a lot from a nursing supervisor to a deputy minister. And we worked with them in multi-week sessions each year to basically undertake and develop these particular projects. We also started by trying to say, what do we know? How can we elaborate a little more on primary health care? We've gone through the period of the Ottawa Charter for Health Promotion. We began to talk about social determinants of health. Public health epidemiology was moving more and more into kind of a critical analysis of economy and labor markets, environment. So how could we stay true to the principles of Alma Ata, but put them into a more recent context? So we said that comprehensive primary health care seeks to intentionally change equity and access, but also builds community empowerment in some way, that it reduces risk by addressing some of the social and environmental determinants of health, increases participatory mechanisms, so not just about voluntary health workers in poor communities, but to increase the capacity of people to engage in the political processes of change, not just providing services, but even changing the policies at the regional or national levels of their countries. And then, of course, intersectoral action, all of which we thought would lead to population health outcomes improvements. Now, we didn't think that we would ever find projects that did all of those things. This is still like Alma Ata. This is ideally what they're going to try to do. But they had to be involved in at least 2 or 3 of these kind of outcomes or goals in order to be part of our study. So what we eventually did with our study is we eventually we had multiple articles, a whole bunch of different outcomes, but we also published a book where we synthesized about 9 or 10 of the studies in separate chapters. And you can download it for free. So that was one of the conditions of doing the book, was that it would be freely accessible immediately. So Revitalizing Health for All. what conditions did we find? This is a very brief summary of, 20 projects in 16 countries. The importance of well-trained and supported community health workers. Sometimes these could be voluntary, but what we found is that even in those countries where they were voluntary health workers and they enjoyed the work they did, they wanted to get paid, and they wanted to be part of the formal health system. So there's a really interesting set of tensions with community health workers. Are they there representing the community's interests to the health system? Are they there to bring the health system closer to the community? More informal and informal mechanisms for participation. More co-partnership, meaning that there was a rhetoric, and still is a rhetoric, that the most comprehensive and empowering or authentic primary health care is the stuff that's bottom up from the community. Well, we had that tested in one country, and the assumption of the researchers was that their little kind of bottom up primary health care program would be the most successful. Then they also had one which was top down, very institutionally driven, kind of a cookie cutter approach to this is how you do it. And then we had another one which was a hybrid, where they developed a partnership between the institution and the community. Perhaps unsurprising, or what should be unsurprising to those of us in the room, is that the most successful program was the one that was the partnership. Because you can have a mythology of the community, that the community can be so empowered, and yes, it can be, but it also requires resources. It sometimes requires technical assistance. The issue becomes, how do you kind of, in those relationships, how do you design it so that power and authority is shared equitably and you don't have dominance by one over the other? Support for community advocacy, but the fundamental one, and this came up very much in our work in Latin America, is that where we saw the best health outcomes and the most indication of comprehensiveness was in countries where you had a left of center or center-left government that was committed to concepts of equity or social justice, and also to trying to ensure that services and programs reached as far towards the marginalized populations as possible. So the political context became very much a defining element of whether or not primary health care could be more comprehensive. Now I'm going to shift and kind of move to Canada, so my own country. And Canada, we have a number of things called community health centers, and I know you have health centers like that here in Chile, and most countries have health centers. These grew out originally of community movements that then became accepted or more institutionalized by governments with different kinds of funding. So we have a number of these in Canada, well over 700, and about 7% of the Canadian population gets its primary care services through these community health centers. But what's interesting about these community health centers, they work with primary health care teams. So not just doctors, but nurses, nurse practitioners, educators. They have health promoters and health educators. They have social workers. They have some of the different health practitioners as well. So you'll see some of them have chiropractors, they have massage therapists, they have physiotherapists, occupational therapists. So they're quite vast in terms of the range of programs or activities that they support. But their governance is important. So a recent study looking at the health centers in Canada found that 60% were governed by the state, by the health ministry or associated service. So as these community health centers became more popular and more institutionalized, they also got brought more directly into the line, command, control relationships of government ministries. 40% were still community governed. They got their money from the governments and from other sources, so that it was still kind of considered to be a public service. But they were governed by local boards, elected boards, with a lot of committees and other forms of participation. Now, why that's interesting is that this study tried to, you can't read the slide too well, but it tried to look at what was the difference in terms of the kinds of activities that these health centers got involved in, depending on whether they were governed by the ministry or governed by community boards. And what we found in this particular study is that although all of the CHCs had a variety of non-medical primary health care programs, so working on things besides just primary medical care, those that were community governed were much more likely to have programs on food security, on housing or homelessness, on poverty and income support, on advocacy, on social determinants. Now, we found the same thing when we did more studies on primary health care reforms in Australia, where we looked at, during a period of real neoliberal aggressiveness in health policies in Australia, we found that a number of these community health services that had done a lot of community development work, a lot of community empowerment work, all of a sudden, they were basically told, individual lifestyle counseling, right? Diabetes control programs. Your only reason to exist is to keep people out of hospitals, right? So that's what you do. So we had this whole backslide into lifestyle kind of issues and very individual issues, except those services that had elected community boards, because those boards were able to put a barrier between government dictates and actual programs. They still had to negotiate to get their funding, but they were much better positioned to be able to respond to community needs and issues and not simply follow kind of the mandated programs. So, moving on. We have seen this transition over the last 40 years from primary health care, which is health, with the very idealized definition of the WHO, is a state of complete physical, mental, and social well-being, which I think is a fine definition as long as you take complete out, because you never get there. So it's a state of increasingly improving physical, mental, and social well-being. And the attainment of the highest level of health is the most important worldwide social goal. Okay? The realization requires the action of many social and economic sectors in addition to the health sector. So that's right out of Alma Ata Article number 1. So that's the axiomatic starting point for primary health care. What do we have now? What we have is universal health coverage, which is equity and access to health services. So those who need the services should get them, and not only those who can pay for them. That the quality of health services is good enough to improve the health of those who receive them. I don't disagree. Oh, sorry. I don't disagree. I knew I'd forget it at some point. I'm getting carried away. I don't disagree with the quality. I don't think any of us should disagree that health services should be high quality. But the emphasis is the financial risk protection. So what we're really seeing is that this universal health coverage is fine as far as access to health care goes. But you can see how universal health coverage risks taking us right back the path of selective primary health care, omitting all of the more health promotion or disease prevention or equity orientation and social determinants actions that were still so solidly embedded in the Alma Ata Declaration. And you see that when you look at things like, there was a 2013 Lancet Commission that was to mark the report, the 20th anniversary of the World Bank's very influential report, the 1993 Investing in Health, which was all about kind of economic cost savings and where do you put, where do you get the biggest return for your investment of a certain amount of money. And that report essentially argued that publicly financed insurance should be restricted to essential healthcare intervention only. Now, this is in 2013, right? And that anything that was other than most essential or pressing health service should be privately insured or paid for by high-income individuals. Really? So while it's undeniably an important goal, universal health coverage, which this commission, the Lancet Commission, was championing, really retrenches selected primary health care in which health care is envisaged as, and I quote, bits and pieces of a jigsaw puzzle connected only by a common financing pool and by regulation of any of the private and public providers. So universal health coverage has changed the language of alma mater from promoting health for all, or at least kind of trying to achieve that in some way, to essentially, let's make sure people don't become too poor as a consequence of having to pay for their health care. Now, I assume that you're familiar. Oh, I see. What happened here? Oh, somewhere, I think the slide, I may have glossed over it. That's what I was looking for. Okay, so you're probably all familiar with this little slide about how do we achieve universal health coverage. As a government, I would say, kind of like, where would you start? Which axis would be the most important? Now, after a lot of debate, there is some consensus that universality of services, so making sure that you had universal access for everybody to these services, should be given priority at lowest cost sharing possible. And they're saying preferably through fully funded public insurance. But for health issues that disproportionately burden the poor or marginalized, this is where they place the emphasis. So it's universal services, but for those services that primarily kind of affect the poor. The problem with an orientation towards ensuring access primarily or giving priority to the poor populations, and I think this has been experienced in countries like Brazil with its SUS, is that if you leave out universality for the middle or higher income populations, then they lose faith in a public system. They begin to react against having to pay taxes for it, and they get angry, and they start to sort of build up private competing systems. So one of the lessons I think that successful use of health system reform has been cross-class solidarity, that you need to build a cross-class sense of purpose in the health systems that you create. If you segment and sort of say, we'll have this service for poor, and this service that's public, and this service for the rich, and that's mostly private, it's not going to build a sustainable or health-promoting system. Now, what we also see is that this focus on the financial aspects of universal health coverage continues. So this was a statement in 2016 leading up to kind of the endorsement of universal health coverage, which is now, of course, part of the Sustainable Development Goals. I italicized a few statements here. That the demand for health services may be infinite while resources are limited, which leads to kind of, we should give priorities based on cost effectiveness with respect to health outcomes. But what this doesn't ask is why are resources limited? We have a mythology, which is a neoliberal mythology, of scarcity, that we don't have sufficient resources. So we need to kind of keep them very modest and very small. That's what universal health coverage should do. I'm going to challenge that in just a moment as I wind up my talk. But one thing that we also saw was how we kind of wound up moving from one target to another. So the first proposed target for universal health coverage in the Sustainable Development Goals was the fraction of the population protected against catastrophic out-of-pocket health expenditure. And it really should be zero. So that's what you aim towards. And that got translated into the number of people covered by health insurance or by a public health system per thousand population. Well, the problem with this is that you can easily achieve that target by having a mix of private and public health insurance, which doesn't in any way sustain a functioning health system or an equitably accessible health system. So many people got very upset with that and pushed back against that, and we did wind up with a slightly different target, finally, after some protest. So again, proportion of population with large household expenditures on health as a share of total household expenditure. But there was pushback in many respects around universal health coverage that really represented the interests of private health systems and private health insurers. And that's something that we're still very much kind of doing battle with around universal health coverage. Now we have a new declaration that's going to happen. I can't remember whether it's late September or in October or quite when the Astana meeting on primary health care is taking place. The draft declaration is already out there. I can tell you it's got some good elements. I mean, here's 3 primary health care principles. Empowering people as advocates, that's good. Addressing the social, economic, etc. determinants of health, that's good. Ensure strong public health and primary care through people's lives, that's good. But there are many parts of this Astana Declaration which are not so good. In fact, the People's Health Movement, we've actually drafted an alternative Astana Declaration on primary health care. It's not released yet, but we did draft an alternative. So, when we talk about empowering people, it still focuses on empowering people to lead healthy lifestyles, not empowering people to create politically equitable systems of governance or policy. The other thing it does is it locates primary health care as a means to achieve universal health coverage. Where those of us who know about primary health care say, it's the other way around. Universal health coverage is one small financial aspect of achieving primary health care. Don't subordinate primary health care to universal health coverage, okay? Because you'll never get out of selective kind of programs or financing by doing that. In addressing the Sustainable Development Goals, it talks about engaging and regulating the private sector, but avoiding political and financial conflicts of interest. To me, as a political sociologist, I say, that's not possible. There are always going to be conflicts of interest between public and private actors, and even between different groups of private actors. More fundamentally, there's absolutely no reference to global wealth inequities, to the role of progressive taxation, to global funding mechanisms, or to climate change. And instead, you have sessions at the Astana Conference about working with the private sector on health financing, on health system development, on health services delivery. Not a very pretty picture. So I would say that, to sum it up, the big risk that we face right now in this transition from primary health care to universal health coverage is privatization. The privatization of ownership, who owns the health systems, the health structures, the health services. Privatization of responsibility, where a lot of government rhetoric now is about individuals need to be responsible for their health. To the point where in the U.S., a U.S. branch of a Canadian health insurance company recently announced that what it wants to do is track through compulsory use of the Fitbit watch all of the health indicators. What the energy levels are, what the calorie consumption is, what the hypertension rates are, or heartbeat, all of this stuff. It wants all your health data, and it wants to use that to basically say that if you don't do these things, you're going to have to pay more for your private health insurance. So the responsibilization of the individual, right? We all have to become privately responsible. Privatization of provision, privatization of finance. So we're still seeing kind of the growth of private health insurance markets. And then privatization through markets, which is about creating conditions where private sector can compete with the public sector for government or social insurance schemes. Now this is happening, this continues to happen, and this continues to be the issues. They're going to talk about doing this at Astana in this this new declaration on primary health care. So, just as an example, I was able to comment on some of the briefs around the role of primary health care that are being put forward at the Astana conference. And some of the arguments that are made is that there's an alignment of interest between private and public sectors that could be leveraged in primary health care. Well, most of the available evidence suggests no, not really. That the private sector is a source of service capacity, greater efficiency, managerial expertise, technology and innovation, investment and funding. Well, it might have some of those things, but this is an unreferenced mythology that the private sector does all these things, and the public sector, we just waste money. Right? We don't know what we're doing. So the private sector has all those wonderful attributes, but that's an ideological claim. It's not an evidence-informed claim. And most dangerously is that the Astana kind of conference is going to be considering the role of private-public partnerships. So we know about public-private partnerships. I believe you have a lot of controversy about those in Chile, where private investors will provide a certain amount of money with a contractual arrangement of repayment over multiple years that would allow the creation of a quasi-public institution. So it could be usually a hospital or maybe a health center or something like that. PricewaterhouseCoopers, one of the managerial kind of consulting firms, when they were pushing around the importance of these public-private partnerships, they first of all noted that the future value annually of healthcare as a financial sector worldwide is going to be more than $70 trillion. Well, investors love that idea because we know that if you make that private investment, it will be backstopped by the government. So if things fail, the government will bail you out because the government cannot lose or risk the loss of political capital by having some of these health systems collapse. What it points out is that for investors, one of the problems is that we have to change our labor laws and unions because, translation, we need to pay workers less. We know that in health systems, one of the major costs in health systems, apart from new technologies and drugs, is people, right? Health workers. So it says, well, we've got to get rid of the labor unions and be able to kind of outsource. We need to put in place user charges. Otherwise, we're not going to be able to make money. And the real profit is not just in taking on service delivery. It's in taking on service delivery and not just helping to build the infrastructure. So this is, again, in concert with public systems, we're going to create very large, very massive, and very profitable private systems. One of the most striking examples of this was what's claimed as the success by the International Financial corporation. Now the IFC, the International Finance Corporation, is the private sector lending arm of the World Bank. So it lends money at reduced commercial rates. So it lent Lesotho money to rebuild its public hospital as a public-private partnership. And in truth, the services at that hospital now are much better. The staff like working there, it's cleaner, it's, they have more effective technology, etc. But the reality is that hospital serves only a small portion of the Lesotho population, and it's consumed now over 50% of the public health system budget. It wasn't supposed to. But the arrangement with the private investors and the loans were such that the investors were not getting the return that they were promised on the basis of how they were administering this hospital. So the government had to keep putting more and more and more public funds into this kind of private-public hospital. And of course, that's at the cost of what it is not spending on providing primary health care services to the vast majority of the population in the rural areas. Indeed, the most comprehensive evaluation of public-private partnerships, and this was done by the European Commission, concludes is that these are the most expensive way to fund projects. They're non-transparent, not accountable to auditors, parliaments, or civil society groups, and that it is much, much cheaper for governments simply, if they need to, borrow on the bond market to be able to provide this infrastructure. Right? When you bring in the private sector into this, the private sector is interested only to do one thing: accumulate more capital, also known as profit. And because it's secure, because they know governments will bail them out if they run into a problem. So, to summarize, universal health coverage runs the risk of being held hostage to all of these kind of machinations of a publicly buttressed but poorly regulated health services market economy. And really a visit back to the ideals and tenets of Alma Ata, which are partly there, but not fully enough there in the draft Astana Conference. And if we want to consider this idea of scarcity, this is a kind of an ongoing study or tracking that I undertake, and it's kind of the neoliberal period. Now, we only have data from the World Bank going back to 2002. But if you monetize what the taxation rates are, so we have data that tells us what the global average taxation rate is per year. And we have data on what the gross economic product of the world is per year. And when you do the math on that, you find that in 2002, almost $30 trillion was untaxed income. So this was privately held income, not wealth, but just income. But in 2016, it's $65 trillion. So we see this massive explosion in privately held income. And we know that it's not just the 1%, but it's the 0.01% that holds most of that income. So our taxation rates have not in any way allowed us to be able to provide the public structures that in the 60s and 70s and at the time of the Alma Ata Declaration we were supposed to be able to do. So I think one of the things that it tells us is that we need to very aggressively repudiate and disown and discredit the concept of scarcity, that governments do not have enough financing to do this. That's why we have to work with the private sector. The only reason that we don't have that amount of public funding is that 40 years of tax competition and unfettered open liberalization without appropriate policy checks and balances have allowed governments to sort of see more and more of the economic wealth go to fewer and fewer private individuals. So if we want to have a bit of a revolution around primary health care, we can start with a revolution around progressive taxation. Last slide. So the question, is it simply, you know, where are we at with primary health care versus universal health coverage? In our understanding, this is from our People's Health Movement comments about the Astana Declaration. Primary health care includes actions to address social determinants of health as well as community participation, and is broader, and indeed, as I said, it subsumes universal health coverage, not the other way around. UHC is narrowly defined as financial protection, so at a minimum, UHC should be defined as universalist, based on social solidarity, and built mainly on a unified public funded system, with most service provisions through public institutions. So that's the somewhat hopeful note that I can leave you with.
Okay, thank you, Rob. I think it has been very enlightening. I think it's a very important topic for many people who are working on health system and financing of the health system here in Chile. So the floor is open for questions of the public. Sí, okay. Sí,
Professor Pierre, at the School of Public Health. And I wanted to ask you, one of the things that we struggle a lot, and something like that too, is about how do we see primary health care as a level of care, primary level of care, or how do we see it as a strategy? And so when you're talking about it's a strategy, not really the first level of care. Okay. So, and one of the things that we struggle a lot here in Chile and probably in the world is how do you measure that? How do you approach primary care strategy not as a first level of care? We were participating, and people here participated, some of the people here, in an initiative by the what's it called? Primary health care initiative. Primary health care initiative. Yeah, it was to actually measure performance in primary health care. And one of the things that we had to do at the very first beginning of the initiative was we're going to define primary care as the first level of care. And that's the way we're going to measure indicators. We're going to measure if diabetes was treated correctly and we're going to measure problems. Do you have any approach for measuring things in this other sense? Because I really think that we are very, and that's also why neoliberals are very successful at transmitting narratives, because they show you a way of measuring things. And they show you graphs and they show you indicators, and you're like, you know? How do you approach that with this other perspective? Yeah, how do you do that? Do you have an answer for that?
I do have an answer. I have sort of an answer. First of all, I think that every time primary health care is discussed as being first level of care, primary care, say no. That is primary care. It is part of primary health care, but it is not the totality of primary health care. So don't be confused on that. In terms of, I mean, you want to look at these are the principles that you would look at in terms of saying this is what we want to measure, this is what we want to have some accountability for. It requires different approaches to evaluation. It will require some more qualitative approaches, some more kind of more almost ethnographic sorts of studies that would document, because when people kind of feel more, for example, are more empowered or feel more empowered or have that sense, you can observe changes in their behavior. And we can kind of show from other research evidence that people who are like that are going to be healthier regardless of anything else, regardless of all the other lifestyle factors, et cetera, et cetera. They're still going to be healthier just because of that experience. So you need to find ways of being able to document that. And so here's the partial answer. Sitting in the front row as I point her out, is that EPIS has been doing, I think, a lot of work on trying to look at different ways of documenting some of those more local level transformations or actions, those issues around empowerment aspects of the social, economic, or environmental conditions. But then what academics' role are, okay? The academic role is to take some of the programmatic experiences that are happening at the levels that EPIS does a great deal of its work with, validating the kind of techniques or measures or accountabilities that those local levels are working with, and then making sure that the ministries actually understand that as well. So you've got a kind of a three-way relationship. That was not by the way, an unpaid advertisement for FS. I get no money for it, but it was an advertisement.
Okay, that's clear. More questions? Pedro,
first of all, I want to congratulate you for your presentation. And I used to work some years ago in WHO in Bajo. And one of the things that we're trying to do is to put health topics in the agenda. Because WHO is not above the governments of different countries. And times change. And maybe at one point in time, it was the right time to put that topic on the agenda. But since times change, maybe trying to put the same topic on the agenda again is not enough to put health as a priority in the different countries. And maybe at this different point in time, it makes more sense to put something like universal health care. I just want to have your thoughts about this different point of view.
Can we take another question and then respond to both?
You mentioned the prioritization of responsibility as an issue, but it seems to me like in some countries like Mexico, my country, we are really paternalists toward this kind of topic, and we assume that responsibility is even from the government. So sometimes I wonder to which level it goes to the person and it goes to the government. Because as I mentioned, I don't know in other American countries, prioritizing in mind usually is toward the government. And I don't know if it should be like that.
thank you. Scarcity.
Yeah. No, but he's getting his 10,000 steps today. WHO, universal health coverage is, maybe that's the term we have to use now. Yes, I mean, you can't really, it's not useful to close the barn doors after the horses have left. And with universal health coverage, the horses have already left. WHO is not going to change its direction around that issue as a consequence of the Astana Declaration. I think it becomes more a matter of politics within individual countries to basically sort of lobby hard and argue hard for what the principles were at primary health care. And fundamentally, it comes down to revisiting questions about what kind of an economic model do we want? What kind of taxation or redistribution policies do we want? And to challenge the fact that we only talk about the role of the private sector in what used to be the public areas of practice, because we basically let the private sector get away with it. And so there are political issues that we should be rallying around within countries. I really kind of largely indifferent these days to these multinational gatherings that issue declarations, because the declarations are usually so mildly phrased and unbinding and not wanting to offend anybody. If you look at the crises we're facing now in terms of global inequalities, kind of the species extinction, including ourselves, in terms of what's happening environmentally, and how that plays out in terms of the huge mess of migration issues that we're facing as people are trying to move to try to have some sort of sense of security in their lives. That I think it's time to be outrageous, not a time to try to be, kind of like softly diplomatic. Now that sounds a bit strange. I'm looking at Leo Nell there, because we just finished 3 days of meetings on a research project around global health diplomacy about how health can influence different sectors, especially foreign relations. And there you have to, there's certain games you have to play in terms of how you position it. But all of us, whether we're academics or whether we work in government or whether we work in civil society organizations or NGOs, we're also citizens. And I think as citizens, we need to reclaim our voice around some of these fundamental problems and reclaim it very loudly. So WHO, they'll stutter around, but they are a shadow of what they were on the international health policy scene, compared to what they were when Hoft and Mahler kind of tried to pronounce the health for all. So we are in a different political climate. I think that we want to work to preserve or strengthen WHO. One of the problems we face with the WHO is that it's decided that it owns Sustainable Development Goal 3. There are 17 Sustainable Development Goals, and many of the other goals have direct implications for health equity outcomes. So what is WHO doing around kind of engaging more aggressively around issues of trade, economy, labor market protection, social protection, and so on? Now, up to the privatization of individual responsibility. I'm not sure I fully understand your point, but what I would say is that the kind of privatization of responsibility I'm talking about is when you have the obesogenic food industry saying we don't need to be regulated because it's individuals who make the bad food choices, right? We don't, it's up to them. So what you need to do is you need to educate people to make better food choices. But meanwhile, we'll continue to sort of deceptively market, advertise, constitute unhealthy ingredients in our food products. Because after all, it's the individuals who are responsible, not us. So that's what I mean by the privatization of responsibility, is that the discussion, when we had the meeting in Rio de Janeiro after the completion of the Commission on Social Determinants of Health, and about 2 or 3 years after that, there was a big gathering in Rio, and they had the Rio Declaration on the Social Determinants of Health. Oh, another declaration. Okay. Our government, in Canada, we had a very conservative government in power at that time, and our government's chief public health officer, when he had to sort of present to this conference. Now, bear in mind, Canada had we played a very major role in that commission. We were all over the knowledge networks. We had people who were commissioners themselves. So and we provided a lot of funding to that particular endeavor. But when the Chief Public Health Officer of Canada got up, he was told that regardless of what the conversation was or what the issue being discussed, he could never use the word regulation or legislation. Right? Forbidden to talk about public regulation or public legislation. So when that's the kind of level, I guess, at the privatization of individual responsibility I'm talking about.
Thank you, Ron. ¿Más preguntas? ¿Mi cuestión?
We're about finished.
Okay.
Yeah.
Okay. Thank you very much, Ron.
Okay.